In today's episode, I'm going to be teaching you how to do a transthoracic echocardiogram, the full scan. We're going to go through all the protocols and windows and measurements. Your foundation is going to be based on this entire video. So let's get into it. So our first image is going to be our parasternal long axis image, and it's going to be a deep view. We want to be able to see if there's any pericardial or pleural effusions in this view. So we're going to have our depth to about 20 to 30 centimeters. If our LV ever apically blunts or shortens in or looks a little bit rounded, we can just rotate and open that up. We can image store that. And now we can start dropping our depth back to our 2D view as well. Okay. Again, we want to keep the LV as open as possible. Clear up that chordae and papillary muscle, and we want to have central coaptation of the mitral and aortic valve, and everything looks symmetrical, so we can image store that as well. One of the first measurements we're going to be doing is our LV dimensions, looking at the interventricular septum, LV diameter, and the posterior wall. And we're going to be measuring from leading to leading edge. So at the start of the IVS, excluding any RV trabeculation, down there, and then from the leading edge there all the way down to the posterior wall, making sure at the basal segment of the LV and down to the pericardium, just where that white bright line is. And we can image store that as well. And now we're going to scroll forward to end systole, which is when our LV cavity is going to be at its smallest. And we're going to go there, often coinciding with the end of the T wave. Again, cutting trabeculations down to that wall. And our EF is looking normal as well. The next thing we're going to be doing is looking at the mitral valve. So we want to get a zoomed view, so we can click our zoom function and come all the way in. And we want to show part of the LA and LV and get rid of any of that pap muscle as well. So we can tilt and get our 2D image of the mitral valve. Then we can add some color to look for any mitral regurgitation. Something that's very important when you're looking at your regurgitations is to pan through the valve. Often, jets can be eccentric, and even in this view, you can miss them. Don't forget, we're looking at a 3D structure and cutting through 2D imaging planes, so it's very important to pan through. And it looks trivial here for us. Image store that. Next, we can have a look at our aortic valve. So same thing as the mitral valve, we're going to click zoom function to have a look at that valve. Come right in, and again, central coaptation, and we want the root to be as open as possible, so we can rotate if it is a little bit closed off. And color. Again, panning through the valve, looking for any eccentric jets that may be hidden. Happy with that, we can image store that too. One thing I also like doing is giving the cardiologist a bit of context. So zoom out, and I also like doing the color for the mitral and aortic valve together. So just a little bit of added detail as well. Panning, again, showing those jets, if any, and we can image store that as well. Next, we're going to be doing a M-mode assessment of the valves. So we want to intersect the leaflet tips and not the annulus. M-mode is extremely useful because it has very high temporal resolution. So we can image store that. And here's our M-mode trace. We can see the LV cavity. We can see our E and A points, the interventricular septum, and our RV. Now we can do the same thing for the aortic valve. So again, we want to hit the leaflets and we want to be cutting through the root. This is slightly off axis, but we can still probably get a really good MO trace of this. Okay, we can see our right and non-coronary cusps, the diastolic closure line, LA and aortic opening, as well as the RVOT. Now we want to be getting our ascending aorta, which is often a rib space a little bit higher. So we can go up on the patient's chest and reduce our depth to come in. Making sure we can see the lining of that, and we can image store. And then our first measurement for the aorta is going to be leading to leading edge for the ascending, and it's measured at the start of the QRS. Now for our LVOT, we can trace back. We want the aortic valve to be open as much as possible, and this is going to be during mid-systole. And this is going to be inner to inner edge. We can trace at the insertion tips of the leaflets or have 5 mm beforehand. And scroll forward. And we want to get the sinuses of Valsalva, or our AO diameter. And again, from the hinge points of the cusps, leading edge to leading edge for these ones, and all the way down. The next thing is going to be our RV inflow. So medial tilt towards the sternum, and now we can see our right heart. We can see the RA and RV together. Image store that. Zoom in to have a look at the valves and assess for any growth. Sometimes patients have infective endocarditis, thrombus formations, or even Marfan syndrome, which does affect mitral valve prolapse. Sometimes it can affect the tricuspid too. We're going to add some color and again pan through to see for any eccentric jets. Still trivial. And we can align our cursor with the TR and run a continuous wave Doppler through that. TR is going to have a baseline of 3 meters per second, so we can clean that up and adjust your gains and reject velocities as required. We're not really seeing much here. So the next thing is our RV outflow. So we're going to tilt and point towards the left shoulder, and here we can see our main pulmonary artery and our RVOT. You can image store that and add some color over that valve as well. It's looking trivial. Again, panning, still trivial, and now we can run our cursor through that, right where that PR is. We're going to put a continuous wave signal. We want the scale to be between 2 to 4 meters per second, depending if there is any pulmonary stenosis. And we can either measure our PA-EDP, which is PR early Vmax, or our PVmax as well. I'm going to readjust our scale here just so we can see a little bit better and cover 2/3 of the screen. Just so you can accurately measure. I'm going to pause that here. And PVV max. And again, chin, not the beard. Good. Next, we're going to pulse wave the pulmonary valve. And just at the tips, parallel to flow. And we want to see that closing click to make sure we're close enough for the valve. Here, we're going to measure our PV acceleration time. Just from the start there. Normally, we want this to be over 100 milliseconds, and if it's less than 100, it can suggest higher pulmonary pressures. The next view is our parasternal short axis. So we're going to rotate 90 degrees from the parasternal long axis, and we want to have the aortic valve centered. So we can rotate, and end up at the aortic valve level. We can see the RA, main pulmonary artery, tricuspid valve, RV, and LA here as well. And just clean that up slightly. We can have a zoom in. Key feature of being on axis is the Mercedes-Benz signal, which is that little part of the aortic valve. We can see the non-right and left coronary cusps. We can put some color over that as well. Panning through the valve. I like doing a bit of simultaneous here as well. Can't see any regurgitation. I'm going to swing the tricuspid valve over to the center, and this is for our TR assessment again. Put some color over the valve. Cover the RA slightly and pan. Again, setting the scale to 3, and we're not seeing much of a signal here. So we can just image store that. We can also reassess our RVOT signals in the parasternal short axis over here, so we can see the pulmonary valve. Add some color, continuous wave. And again, we can do our PVV max from here, and as well as our pulse wave for the PV acceleration time, same as the parasternal lung axis. So if your images are pretty technically difficult, this is another way where you can get the same measurements. Moving on, we can look at the interatrial septum. So we want to get a zoomed view and run some color through it. This is where we can have our PFOs, ASDs, or even septal aneurysms as well. So when we put our color, we want to reduce our velocity scale, or our Nyquist limit. I like dropping it between 30 to 40 centimeters per second. If it's too high, we're going to miss the shunt. So again, panning through, and not much. So we can just image store that as well. So the next is the mitral valve level. So we're going to tilt towards the apex, and we can see here our fish lips, which is the signature of the mitral valve. We can see the anterior and posterior mitral valve leaflets. We will put some color over them. Make sure you don't make your color box too wide, because then you start losing frame rate, and we don't want that. Put some simultaneous, some color, panning through. Again, a very small flash of regurgitation, trivial. Also, don't be afraid to get creative. So if we wanted to look at the TR, we can swing it across, tilt upwards. Maybe there's an eccentric jet we can catch at this level. But again, still trivial, so not much. So you can run your cursor through there and continuous wave if you needed to. Again, resetting our scale. So next is PAP muscle level. So we can tilt down, getting rid of the leaflets, down. And we want to be looking for the insertion points. We can see the posteromedial and anterolateral points there, as well as our RV above. Let me just do that. These assessments of the walls here are going to be very important for your ischemia. And when we come down to the apex here, it's going to be important for any thrombus detection too. And again, we want to get that base of the apex, the smallest point, just where it's contracting. And we can reduce our depth here. If you wanted to, you can also put some color over it as well. That's that done there. That's pretty much our parasternals all finished. We looked at some of the valves, regurgitation assessments, got our main measurements done as well. Again, remember, it's a 3D structure, and this is a 2D plane. That's what the ultrasound is. So when we went from our long to short axis, when we had that aortic valve in the center, when we rotate, it's going to be on the center again for the short axis. Keep that in mind, because often when you're training and you're starting, you start slipping and sliding and tilting and rotating, and again, you're cutting through it in a very off-axis way. So be mindful, take your time, and small movements. Next, let's get our apical 4-chamber started. So our first image is going to be our apical 4-chamber, and we want to be able to see all 4 valves symmetrically. We can see our LV, RV, LA, and RA, and again, no apical blunting. We can always pan, rotate, tilt, making sure that this is the image that we're going to be getting. And we can image store that as well. The first measurement is going to be our left atrial volume. So we want to go all the way to end systole, which is when our LA is at its largest. Just there. And now we can start tracing our left atrial volume for 4-chamber. Tracing the blood tissue barrier, and we're going to be starting at the lateral annulus. Exclude the LA, which sometimes people do, and any of the pulmonary veins, which is going to overestimate your LA. Going to the interatrial septum, which is really thin, and all the way down. This is the best way to get an accurate measurement for it. Image store that. We're going to put some color over the mitral valve. Again, same thing. Panning, looking for any MR, covering the entire LA. Sometimes MR is posteriorly directed, so I like tilting towards there, and having your scale set to 6 as well for continuous wave. We're not seeing much. You can also increase your gains if there was a little bit, but yeah, nothing to see here. Now we can increase our depth to look for any pleural effusions again that we can see on the left, or any pericardial if it was circumferential or loculated as well. Image store that, nothing really to see. And now we can add some color to investigate the pulmonary veins. Now remember, red is towards the transducer and blue is away, so our pulmonary veins are going to empty into the LA. We're going to be seeing that red flash down at the bottom there. We can put our cursor through that and get a pulse wave signal of our pulmonary veins. So just at the bottom. Pulmonary veins are really good for diastolic function, which is going to tell our LV pressure, and we can also estimate our LA pressure from that as well. We can see our S, D, and AR. If MR was severe, you'd be able to see flow reversal in the pulmonary veins. So again, it's a good way to distinguish moderate from severe too. Next is our transmitral flow, EA. We're going to pulse wave just at the leaflet tips and using color to guide us. And it's not always central, so we want to be where that red jet is over there. Pulsing there. When it comes to atrial fibrillation, you're not going to see that A wave. So we want to average those 3 E signals for consistency. We can see our EA here. And just measuring our EA velocities. Okay. Normally we want our EA to be 1.5 to 2. Anything less than 8 is going to be impaired, and anything more than 2 is going to be restrictive diastology. Next is our TDIs. So we click our TDI function, and we'll go down towards the septal annulus. Okay. Otherwise known as the medial annulus as well. And here we can see our E prime, A prime, and S prime. So we want to be measuring our septal E prime. Okay. And remembering, chin, not the beard. We can reduce our gains to accurately assess that too. Next, we're going to be swinging over towards the lateral annulus as well. And again, measuring the lateral E prime. And this is going to give us our average E on E prime. Normally, we want it to be less than 8. Anything more than 14 is going to be raised filling pressures. Next, I'm going to have a quick look at the interatrial septum. So again, we want to zoom in and narrow that box. Get a 2D image of that. Running our color through as well. and remembering to reduce your Nyquist limit. Can't really see much. Okay, and then we can move on to our apical 5 chamber. Have some superior tilt from the 4, and we want to have that LVOT open. When we see our proximal aorta, that's how you know you're on axis. We don't want just like a little round bulb, okay? And we can run some color through that as well. And if it was aliasing, it'd be indicative of flow acceleration, which we can look at too. Common with proximal septal bulges. Okay, and we can continuous wave that as well to interrogate for any aortic regurgitation, which is going to be above our baseline. Setting your scale to 4. Not much. If probably anything, nothing at all, to be honest. Next, we're going to be doing a pulse wave at the LVOT, just above the aortic valve, and this is going to be for our aortic valve area, which is part of the continuity equation. And again, setting our scale to 1.5 or 2. And we want to be able to see that closing click of the aortic valve. That's how you know you're right next to it and you're on axis too. We can see laminar flow, minimal spectral broadening, and a clear window. So we want to trace all the way down and up. I do like lowering my gains just to make sure I am cutting again that beard. You can raise them after if you'd like. You can save that. And then we're going to run a continuous wave Doppler, again for the continuity equation for AVA, parallel to flow. And I'm going to change my scale all the way down, covering 2/3 of the screen. We want a dense, bright signal, making sure that we are going through that flow as parallel as possible. And again, tracing at that interface. All the way down, 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 and up. Beautiful. Okay. Let me just do that. Now back to our apical 4 chamber, we're going to be looking at the RV focused view. So we're going to swing into a lateral position and bring the right heart into the center, keeping it open. And I'm going to narrow that sector width as well. And we also want to visualize the lateral free wall. Make sure, I know there can be a bit of a dropout, but make sure you show it. Add some color. And again, looking for any TR, dropping our baseline back to 3. Yeah, trivial. Not even a complete jet. Okay, we can image store that. And next for our RV systolic function, we're going to be hitting our TVI. And at the annulus laterally, we're going to hit pulse wave. And this is where we're going to get our RVS prime measurement, which is an indicator of systolic function. We want this value to be more than 9.5. And here's our S prime wave just there. Cool, that's good. And now we can hit an M mode for our TAPSI, which is our tricuspid annular plane systolic excursion, long name. And just from the red-blue interface, along the excursion all the way up. I like reducing my gains to do so. I want this to be more than 17 millimeters. Good. Okay. Again, another way of doing this is zooming in for more accuracy if you had difficult imaging. And then we can really see that TAPSI pretty clearly. And again, getting a more accurate measurement to the top. Similar result. Next is going to be our right atrial volume. And we want to be measuring this end systole when the RA is largest. The mitral valve and tricuspid valve don't always open at the same time. I think they're a frame or two after each other. So measuring all the way around at the annulus, down and up. And there's our RA volume done. Next, we are going to be looking at our RV basal diameter. So we want to reduce our depth. If there's any RV basal dilatation, it can also be a sign of pressure or volume overload. And sometimes with cardiomyopathies like arrhythmogenic RV dysplasia, we'll also have some of that as well. So again, if it looks big, measure it. And normally it should be less than 4.1 centimeters. Maybe a little bit higher. There we go. Again, symmetrically measuring. Let me just restart that. There we go. Just for there. And you can also do your RV mid dimensions too, so just from here, as well as your RV length, your major. 1 second, just make sure we're hitting, again, you're going to be very particular with these measurements, You don't be over measuring and overestimating. When you're a trainee, you always end up calling something larger than what it is, and it's actually normal. So just always be mindful of that. Yeah, just there. A little bit of dropout, so it's kind of hard to see where the apex is, but I think it's there. That's fine. Cool. All done. Next, we can also have a look at our RV fractional area change, and normally this is greater than 35%. Another really good indicator for our systolic function. So all the way where our RV is at our largest, and it's just an area change. And you can manually calculate this after the examination. You can click area, and we want to be able to trace that at its largest. So just here, before the valve opens. And again, on that lateral annulus, all the way up. And stopping at the apex and turning around, down the IVS. And there, that's fine. You can image store that. And scroll forward to, yeah, measuring all the way up, up. Coming around. I'm trying to exclude those trabeculations as well. You can store that as well. Next, we're going to be looking at our LV focus view. So we can reduce our depth, and we want to cut off half the LA, and we want to try and center that LV as well. Making sure we can see as much endocardial definition. And here we can see the infraseptal and anterolateral walls. Image store that. And again, for our Simpson's biplane, we want to be measuring endoastole, tracing all the way around. And this is going to give us our Simpson's ejection fraction. So all the way to the top. And down. And storing that. Good. And then scroll forward all the way to systole. Yep, just before the valve opens. And tracing. Good. Okay, 60% for the EF, which again is normal range. For our apical 2-chamber, we want to be rotating 90 degrees anti-clockwise. Turn. 2-chamber is always the hardest. And it's often the anterior wall that's going to have the most level of dropout just because of rib spacing. But here we can see that the mitral valve coaptation is central. The apex is not blunting. And here we can see the inferior and anterior walls. Some dropout with the anterior wall. You can always increase your gains as well. I'll try and get a better one. See if we can push down on a rib as well. That's always helpful. And here we can see more of that definition for the anterior wall. Good. We can image store that as well. Maybe. There we go. Okay, now we can do the same thing for our Simpson's biplane. Go to endoastole when it's its largest. All the way up, cutting through trabeculation. And wrapping around. You can increase your gains, again, if you want to see that border a little bit better. And measuring there. Good. Forward to systole. And all the way up. Same thing. Tracing around that border. Making sure LV is at its smallest. Between our 4 and 2 chamber, we want to have a difference of less than 0.5 millimeters. The closer you can get your length between your 4 and 2 chamber, the more on axis you are. If you had anything more than 0.5, you're probably off axis, you're cutting it obliquely, and you've definitely foreshortened one of the chambers. Next, we can do our LA, which is our end systole. Again, when we trace, we want to exclude any pulmonary veins and just follow the wall lining. In the 2 chamber is where you see people over tracing the most. So you can always click your trackball, go back and forth, and increase your gains as necessary so you can see that wall lining. Cool. You can add some color. Do that again. Next, we can add some color. And again, looking for any mitral regurgitation, making the color box cover the LA completely. Pan. If you want to do your pulmonaries here as well, you can. Continuous wave and setting the scale to 6 meters per second. I know we saw nothing earlier, but again, being thorough and making sure you're getting the largest jet for eccentricity. If your patient had mitral annular calcification, which is moderate or severe, or even mitral stenosis, we can do something called an MV trace. So we can measure above the baseline. And again, these are our EA signals, but with a continuous wave Doppler. And we want our gradient to be less than 2 or mitral valve area between 4 and 6 for it to be normal. So tracing all the way along EA and then stopping just at the QRS. And then forward to the next cycle. Good. Okay, we just saw that as well. Normal. Okay, for our 3-chamber, we want to keep rotating for that 90 degrees. Rotate, rotate, rotate. And we can also incorporate some superior tilt to open that LVOT. And there's our 3-chamber. Beautiful. We can image store that as well. And again, we can add some color to the mitral valve, pan, get that clip done, as well as the aortic. I'm going to come up there. Setting the color box. If you had very severe jets or even moderate jets of AR, we want to see if it's wrapping around the wall. Okay. Again, you can interrogate the valves, look for any growths. Mitral valve prolapse is another good one as well. You can do your PISA measurements here in your 3-chamber. Come down for our focus view, and we can see our infralateral and anteroseptal walls quite clearly. Better than the 2-chamber, that's for sure. And we can image store that as well. If, for example, you hadn't found any TR, or you did and you want to find the maximum jet, something we can do is called a reverse 3-chamber. So we're going to tilt posteriorly, and we can see our right heart here. Put some color through it. The amount of times that I have found a stronger jet density and even found a higher gradient has always been through the reverse 3. So definitely utilize it. And you can put your continuous wave through that as well. We're not going to see anything because it was trivial. Sometimes this works, sometimes it doesn't. But when it does, you're going to feel very rewarded that you found the highest signal for that TR. So the next thing we're going to be looking at is our GLS. So we can open our 3-chamber. Our GLS is going to quantify the LV's ability to longitudinally contract. It's very sensitive for early indication of LV dysfunction, and it can also detect regional wall abnormalities. If your patient's had ischemia, heart attack, myocardial infarctions, whatever it is, if there's any perfusion abnormalities too, this GLS is going to be really helpful. Ideally, if the wall is contracting correctly, it's going to come up as red, and if not, it's going to populate as blue. And it's all tracking good, everything's ticked, looks like it's flowing well. You can also play with your region of interest and reduce that too. Drop the apex a little bit, to be honest, a little bit too high. Reprocess, and everything's tracking really well. So I'm pretty happy with that. We can just click approve, and at the ECG point, negative 21%. Anything more than 16% is going to be considered normal. So next we can go to our 4-chamber, and again click AFI, and again following through, placing all of those at the endocardial border. Good. You can reduce your ROI again if needed be, but I'm pretty happy with that process. Even though the basal septum is red, it does look like it's tracking, so I'm going to click tick and approve. And negative 22%, which is also still consistent with the last one. Good. Sometimes if you are seeing any regional wall abnormalities and the GLS is telling you that it's normal, disregard it. Again, it's a helpful tool, but you're the sonographer. You're the one making the decisions depending on what you're looking at. So for the 2-chamber, same thing. And we can process that as well. Cool, everything is tracking well. We can click approve. And now we can see our maps here as well, our bullseye in the corner, and all of our GLS measurements as well as the average too. Click that, show the cardiologist in the image store. And once you end this examination protocol, it will save the GLS for you. So click exit, approve, save that GLS. So that's pretty much it for all of our apical windows. I guess the main part of the apicals is assessing LV diastology. We looked at our pulmonary veins, we looked at our transmitral flow, our septal and lateral TDIs, we looked at our ejection fraction to make sure that was normal with our Simpson's biplane, and even our assessment of the right heart. Again, when we were going through the 4-chamber, 2 and 3, that's when you're thinking, okay, 3D structure, 90 degrees, turn, as we're cutting through the plane. The easier it is for you to visualize the heart in terms of its anatomy and where it's located and what you're cutting through, the better your scanning ability is going to be. 2-chamber is the hardest when you're starting. Trust me, I struggled with it. And there's always going to be some level of dropout to an extent, depending on images. Remember, these are the ribs, and this is the ultrasound probe for your 4-chamber. When you go to your 2-chamber, the ribs are going to block the ultrasound part. So one thing you can always do is just pull down on that rib. Not hard, but just enough to help the ultrasound pass through. And a lot of the times, you're going to see that dropout clear up, and you'll have better wall definition, as we saw with the anterior wall as well. Now that we've finished our apicals, we can move on to our subcostals, which is going to be scanning just here, just where that xiphozoid sternum process is. Okay, it's a little bit tight. You're going to be pressing. If you can't get an image, and because subcostals and suprasternals even vary, one thing I like doing for subcostals is getting the patient to lift their legs up onto the bed so they're bent, and getting them to relax as much as possible, and then try and go in for that, as well as breath techniques. But we'll see how this goes. We'll have a look. So with subcostals, we're going to be shooting through the liver, which is what we can see above, and we've got pretty good images. We can increase our depth, and it's pretty much spot on, which doesn't normally happen in a real life practice. We can image store that. Even telling the patient to take a breath in, we can reduce our depth and have a look at that interatrial septum there, which is pretty clear. Again, looking for our PFOs, ASDs, or even our aneurysms. This is where the beam is going to be perpendicular and parallel to flow. So this is where we're going to see most of those color shunts present. Reducing our Nyquist limit, simultaneous, panning through, and we're going to see like a red candle-like jet if there was any shunting, because again, left to right. Yeah, we really can't see much, so we can image store that. Okay, if there was any pericardial effusions or loculated pericardial effusions in the RV, what we can do is, we can keep superior tilting and opening up the RV, looking at the space. This is where we'll see our fat pads. Pretty continuous wave Doppler again, but really couldn't see much. Next, we're going to be looking at the IVC. So rotate anti-clockwise till we can see it there, reducing our depth. And we're going to tell the patient to take a sniff in for collapsibility after we get our 2D image. So we'll get the patient to take a sniff in. Good. And again, more than 50% collapsibility. Our IVC is going to help us estimate our right atrial pressure. We want to see that if it's dilated and it's collapsing correctly. We can use M mode as well to visualize that collapse. We can change our horizontal sweep speed. Look, visually, if it looks like it's collapsing all the way in, you don't have to do this, but this is a quantitative way to make sure that you are at 50%. Just there. Okay, and you can manually estimate that as well, but it's clearly collapsing more than 50% from that change. Okay. Next, we can add some color and look at our hepatic veins. A big way to differentiate moderate to severe tricuspid regurgitation is going to be looking for flow reversal in the hepatic veins. Moderate to severe mitral is going to be at the pulmonary veins, tricuspid, here, pulsing the hepatic vein. And although it was trivial, again, we're not going to see any systolic flow reversal. Good, let me just saw that as well. And we can inferiorly tilt till we can see the abdominal aorta, which is this structure here. We can get some color on that as well after a 2D clip. Sometimes people will accidentally confuse the IVC and the abdominal aorta, so make sure you're tilting to see the two. And we can also get a measurement of that as well to see if it is dilated. This is where things like when it comes to aortic stenosis, regurgitation, these parameters are going to be really good and it's essential. We want to see a red pulsatile jet for the abdominal aorta, so we can pulse that as well. We can see it clearly in color, it's pulsatile and not blue. Again, seeing any flow reversal in the abdominal aorta is going to bump our AR to severe, as well as the color jet and the densities with continuous waves, so putting everything together. So the next thing we can do is our subcostal short axis. If your parasternals are really, really bad or technically difficult, you can always look at them through the subcostal window. So again, getting the patient to breathe in and out, and we can tilt, rotate, swing, do what you got to do to show you that short axis. And it's going to be the exact same view as parasternals. Very small maneuvers for this one. Okay, image store that. I can zoom. And what can we see? We can see our Mercedes-Benz logo. That's our aortic valve. So it's a good way to differentiate from our trileaflet and bicuspid valves. Here we can interrogate the interatrial septum in a different axis. Looking for any shunting. None at all. Okay, that's good. Okay. If we wanted to also get some TR, you know, if the parasternals were difficult too, we can do that too. We can color the valves. We can have a look there as well. I guess the point of doing subcostals, it's always an informative way if you are struggling. Like the amount of times that I've put the probe on the patient's chest for parasternals and you get nothing, this can be your savior. This is where you can get, you know, here we can do your pulse wave, continuous wave of the RVOT, tricuspid valve, the whole lot. So that's our subcostals all finished. And I want you guys to focus on a really important point here. Because the amount of time that I have wasted as a trainee trying to get parasternals and apicals done and there's nothing there. Look, the patient may be large. They can have small rib cages where even pushing the probe down isn't going to help at all. I guess the point is we were being creative here. We were really trying to get all those measurements and we did. Something as simple as determining if the aortic valve is trileaflet, not bicuspid, from the subcostals. Amazing information for the cardiologist. I got my RVOT measurements there. We could interrogate the mitral valve. We could see some of the regionals for the muscle contracting in the short axis, apex. We got quite a lot of information just from that one view. So again, if you're struggling and you're not getting any apicals or parasternals, it's okay. Sometimes I'd go straight to subcostals and start with that. I know we're working through the protocol, but again, don't be so fixated on the one way of doing things. Next is going to be our suprasternals, and then we can wrap up this examination. Okay, so just as I mentioned, real world example, our patient doesn't have the best suprasternal images. We want the probe to be here, sitting at the notch, and the probe marker facing 1 o'clock. We really can't see much. I can see only part of the aortic arch, those two white bright lines, only because my eyes have become accustomed to them. I'm going to reduce my depth and increase my gains a little bit. We want to try and find the aortic arch, which we can see just there. I'm going to image store that. And again, all aortic measurements are going to be at the start of the QRS. So I'm going to scroll forward. We can see it just there, ever so slightly. If you are not comfortable in measuring something that you can't 100% determine or see, don't include that measurement, because we don't want to give fake measurements or overestimate. Another thing you can do is use your color to guide you. So we can see again, just where I measured, it's where the descending aorta is. We have a blue flash. We can put a continuous wave Doppler through that. And this is all for the assessment of flow reversal for the severity of AR. Normal, and we can do a pulse wave signal too. So again, even if your 2D is lacking, your Doppler signals can really be a benefit to you. And that is our protocol all finished. There are a few additional measurements that you can do, like right sternal edge and some of the additional things that I didn't include in this. I didn't want to do too much pathology information, so I just wanted to give you this basic foundation. I'm going to be very honest. I haven't seen a single video online that has gone through a full echo like this. It almost feels like gate-kept knowledge. No one's showing you the full protocol. They might show you some windows, but they're not going to be telling you exactly how to scan. I hope that this was as informative as possible, because on a day-to-day, with the exclusion of pathologies and additional measurements that I do, this is a normal scan. This is what a normal scan looks like. And if you can memorize this and know exactly what we're doing and what the measurements mean and correlate everything, and again, bringing all those 2D structures as a 3D image in your brain, and you're going to excel at what you do. On a side note, there's something that I want to relay to you, and it's something that my trainer once told me. You can teach a monkey to scan. You can bring anyone and teach them the full protocol and get them to memorize all the measurements and the muscle movements. That's not the point of what we're doing here. The point is that sometimes in a real world example, where a patient is in the hospital or is unconscious in a coma or just fresh out of surgery, sometimes none of these techniques work at all. And the images are going to be completely different spaces, and the amount of times I've had to scan on the sternum, on the side, and everything is just completely up tilted. It can be a complete zoo fest. But if you memorize the principles, And you can start applying it in different settings by knowing the context of how to scan, how to do this one to the best capacity possible. That's where you can apply yourself. That's where you can become a great cardiac sonographer. Anyways, that's enough for me, but I had so much fun making this video. It was cool, kind of just, I don't know, just showing you guys the ropes. It was tricky trying to speak to the camera and scan as efficiently as possible at the same time, but I enjoyed this. Trust me, memorize this video, have it in the back of your brain, and you need to know what a normal heart looks like before we start doing pathology, because it can start getting a little bit out of whack. I hope you guys enjoyed the video. Next, we're going to be looking at regional wall abnormalities and ischemic heart disease, which is one of my favorites. And I'll see you guys in the next one. Thanks for watching.